Good morning, everyone. It's my pleasure to welcome you to the Methodist DeBakey Heart and Vascular Center Grand Rounds today. Before we get started, I do have a few housekeeping items that we need to do. Remember that we are broadcasting live via live stream and YouTube. Please use the microphones to ask any questions so our online audience can hear. Recording is always available for your viewing. I would encourage people to consider subscribing to our YouTube channel to get notifications when the videos are added. For our viewers, if you'd like to submit a question, text DeBakey to 37607. Again, that's DeBakey to 37607. You may also submit questions via the live stream feed, and you can find the video at livestream.com let's try that again. livestream.com/HMH-EDU. Want to let everyone know about our upcoming conferences, which will be the Heart of the Woman Conference on April the 27th. Also, cardiovascular disease prevention on May the 4th. And the pre-intern for vascular fellows will be June the 10th through the 12th. With that, it's my pleasure to focus on our speaker for today. As you know, many of you know, Dr. Yousefzai is an advanced heart failure and transplant cardiologist here at Houston Methodist DeBakey Associates. Additionally, he holds the position of Assistant Professor of Medicine at Weill Cornell Medical College and the Houston Methodist Institute of Academic Medicine. Dr. Yousefzai serves as the medical director of our heart failure unit on the Dunn inpatient service. And he's also the medical co-director of our Adult Congenital Heart Disease transplant program. His education and learning is kind of a tour through the U.S., although I noticed that he left out the South. I won't take that personally. But he obtained his medical degree from the University of Illinois College of Medicine, followed by a residency at the Cleveland Clinic. He then completed his cardiovascular fellowship at Aurora Healthcare in Milwaukee, and then his advanced heart failure fellowship at the University of California, San Diego. In clinical practice, Dr. Yousefzai specializes in invasive aspects of heart failure, as well as LVAD hemodynamics, multi-organ transplant, and the above-mentioned interest in adult congenital transplantation. He's made significant scholarly contributions through multiple publications and serves as principal investigator on numerous clinical trials, one of which our site is the leading national enroller, and he'll tell us more information about that trial here, and maybe even mention a sub-study that he's actually pioneered through this study. His research endeavors, again, concentrate on the selection of outcomes of heart failure for the adult congenital transplant population and the nuances of multi-modality imaging in heart transplant patients, in addition to his interest in invasive heart failure therapies. So with that, I'll invite Dr. Yousefzai to come give his talk on advancing care in heart failure, strategies for manage acute decompensated heart failure.
Thank you, Dr. Martin, for a kind introduction. It's an honor to be here presenting in the DeBakey Cardiovascular Grand Round. As Dr. Martin mentioned, in the next 40 minutes or so, I will talk mainly focus on acute decompensated heart failure and managing of these patients. In my disclosure, I'm a site PI for a venous HF trial, and I was involved early on in the posterior aortics, and I will discuss some investigational devices. So objective of this talk is to provide a brief review of the definition, epidemiology, pathophysiology of the acute decompensated heart failure, to evaluate the lesson learned from existing pharmacotherapies in acute decompensated heart failure, highlights both successes, failures, and what we have learned from them, discuss the latest innovation in the medical devices that are shaping the management of acute decompensated heart failure, and finally to explore the evolving paradigm changes in management of these patients and how they might transform the care of these patients. So what is acute decompensated heart failure? Acute decompensated heart failure is a clinical presentation of the symptoms and sign of congestion and poor organ perfusion due to heart failure.
Decompensated heart failure has attained a balance between preload, afterload, intrinsic inotropy, and neurohormonal signaling. When the balance alters, it can cause decompensation. Pathophysiology of this acute decompensated heart failure is pleiotropic and includes multiple factors, including the degree of systolic and diastolic dysfunction, the relative involvement of right and left ventricle, the arterial and venous vascular tone, and neurohormonal and inflammatory signaling. As you know, the heart failure is a spectrum and has been classified in multiple ways. It's classified based on the clinical presentation. That could be pre-cardiogenic shock, cardiogenic shock, refractory cardiogenic shock if this patient still in the cardiogenic shock after treatment. It can be classified based on the functional class. This is NYHA classification 1, 2, 3, 4, and could be based off the structure and symptoms. These are ACC stages 1, A, B, C, D. The definition of them is provided in the slide. For this talk, I will focus mainly on the pre-cardiogenic shock patient. These are acute decompensated patients who are not in the cardiogenic shock and they don't need inotrope or mechanical circulatory support for perfusion. So the paradigm of looking at each episode of acute decompensated heart failure as if the treatment of the patient if we treat this patient, they can return to the natural history similar to the other people with the chronic heart failure has changed. Each episode of the acute decompensated heart failure is recognized as a major event, that it's a marker of a high risk and is significantly associated with increased mortality and morbidity. And as multiple studies have shown, every episode of acute decompensated heart failure and hospitalization is associated with increased mortality and increase exponentially of mortality and decreased survival. So let's talk some facts about this heart failure. The acute decompensated heart failure is the most common cause of hospitalization in older adult. 33% of these patients will be hospitalized within 60 to 90 days. And 66% of these patients will either hospitalized or die within 1 year. And 1 out of 6 patients who are admitted with a heart failure will die in the 60 days. These are pretty grim facts about acute decompensated heart failure, but keep it in mind when we talk about the rest of the talk. So with that, let's talk about the pathophysiology of acute decompensated heart failure. The pathophysiology is very complex and through the different pathways, including hemodynamics, neurohormonal, and autonomic system. The cardiac injury causes inotropic derangement, and the inotropic dysfunction can result in decrease of the cardiac output and direct effect on the end organ perfusion, including the kidneys. The marked sympathetic activation can exacerbate the arterial and venous vasoconstriction. Increased splenic venous vasoconstriction results in a marked volume redistribution from the unstressed to the stressed blood volume pool. An increased systemic vasoconstriction results in elevated left ventricular pressure, increased ventricular wall stress, and exacerbate myocardial injury. The dysregulation of renin-angiotensin-aldosterone system can also have a detrimental effect on hemodynamic changes. Angiotensin causes vasoconstriction and results in the increased vascular resistance, and also causes sodium and water reabsorption and increasing the volume on the stressed blood volume pool. And aldosterone can directly affect the kidney and cause further sodium and water retention. And myocardium releases AMP and BNP to respond to this increased volume and pressure and contract this mechanism. However, this mechanism can be overwhelmed in the patient with a persistent congestion. There's a number of the cytokines that are also involved in the pathophysiology of the heart failure, including a TNF, tumor necrosis factor, TGF-beta, transforming growth factor beta, and interleukin-1 and 6. The cytokine cascade independently can cause endothelial dysfunction, pulmonary edema, and left ventricular dysfunction, and are thought to contribute in part in the presentation of acute decompensated heart failure. So I cannot talk as a heart failure without showing the pressure volume loop. The effect of the preload on the cardiac performance is best explained by the pressure-volume loop. The loop is bound by the end diastolic and end systolic pressure-volume relationship. Compared to the normal heart, which is present in the red, in the heart failure, both the end systolic and diastolic pressure-volume loop, they shift downwards to the right. And that's a reflex of the ventricular remodeling and loss of myocardial contractility. And therefore, the heart operates on the higher volume and pressure and quite inefficient when it operates. In the constant contractile and afterload, stroke volume increases with increasing the preload. This phenomenon is known as Frank-Starling law. In the normal heart, in the gray, the stroke volume increases to a plateau over a wide range of end diastolic pressures. In the heart failure, in the blue, this graph shifts downward, and most importantly, while the systolic volume increases with increasing the preload, at the higher end diastolic pressure, this stroke volume can decrease, also known as descending limb, which here is shown between the point D and E on this blue graph. Therefore, the therapies have been focused on bringing the preload to a more favorable place on the curve, and that's been done by decreasing the preload, decreasing the afterload, and increased contractility. So when I think about the tools that we have to treat this patient, I think about four ways that these tools can work. These tools can be removers, which they directly remove sodium and water. They can be dilator, which increase the venous capacitance and decreasing the afterload, and can be pullers. These are the tools which decreasing the renal venous pressure, and pushers. These are the tools that increase renal arterial pressures. So let's talk about the pharmacological therapy first, and what we have learned from these therapies in this patient. The cornerstone of the treatment of a heart failure involves the management of the cardiac preload. Diuretics therapy is the most commonly approach to the regulating cardiac preload and reducing congestion, and remain cornerstone of the decongestion therapy. If you guys wondered, this is the statue of the mannequin Pez at Brussels, Belgium. So the diuretics are the most used, and they block this, the loop diuretics block the sodium potassium chloride cotransporter. However, it turns out that the strategy of use is not clear. As most of the people know, in this famous dose trial, there was no significant difference in the primary endpoint of the global assessment and the kidney function and creatinine changes based on the strategy of bolus versus continuous flow and high dose versus low dose diuretic use. And there was also no difference in the composite endpoint of death, rehospitalization, and emergency visit within 60 days of follow-up. However, if you look at the secondary endpoint, there was definitely a benefit of using a high dose of diuretics in the clinical improvements, such as net fluid loss, weight loss, decreasing a length of stay, and relief of the symptoms. Therefore, there's a definite role for using a high dose of diuretic, an appropriate dose of the diuretic for the patient who is admitted for acute decompensated heart failure. So what is the story for tolvaptan? Tolvaptan is an oral vasopressin 2 receptor antagonist that inhibits the action of antidiuretic hormone and leads to the loss of free water or aquapheresis. In the Tactics HF trial, 257 patients who were admitted for acute decompensated heart failure were randomized to tolvaptan versus conventional therapy with the diuretics. The primary endpoint of dyspnea, improvement at 8 to 24 hours, and need for rescue therapy was not different between these two groups, as shown in the figure on the top left. However, tolvaptan was associated with significant greater weight loss and improvement of the sodium, the serum sodium. In another trial, the Marine trial, 220 patients were randomized for acute decompensated heart failure, were randomized to tolvaptan versus conventional therapy. The primary endpoint on improvement urine output within 48 hours was significantly higher on tolvaptan, and also the change of weight was significantly higher in tolvaptan group. However, the sign and symptoms of the congestion and the clinical improvement, including the edema, orthopnea, and pulmonary congestion, improved in both groups, but were not different between these two groups. Therefore, there's a clear and use and role for tolvaptan for use in patients with acute decompensated heart failure who are congested on the diuretics, and especially in the patient with the hyponatremia. So what is the story about acetylizumide? Acetylizumide is a carbonic anhydride inhibitor that reduces the proximal tubular sodium reabsorption and may improve diuretic efficiency. The most recent published ADWORD trial was published in 2022. 519 patients were randomized to conventional therapy with diuretics versus adding acetylizumide to these patients. The primary endpoint of successful decongestion was defined as the volume absence of the volume overload based on the congestion score at 3 days, which achieved in 42.2% of the patient on acetylizumide versus 30.5% of the patient with the conventional therapy, which was significant. And at the time of the discharge, among the patients who were alive, the appropriate congestion was achieved in 78.8% of the patient versus 62.5%, which was clinically significant. However, the endpoint of rehospitalization and death from any cause was not different between these two groups. Therefore, there's the role for using acetylizumide as an addition therapy for augmentation of diuresing for a patient who are still congested on loop diuretics or other diuretics that we use. So why is it so difficult to diurese this patient and achieve the decongestion? There's a concept of developing diuretic resistance that can occur with several mechanisms, such as impaired absorption of diuretics in the gut, inability of the drug binding to the albumin due to a low albumin level, reduced renal filtration, either based on the decreased blood flow or increasing the CVP, proximal and the distal sodium reabsorption, and activation of the renin-angiotensin-aldosterone, which can cause diuretic resistance, so the diuretic would not work efficiently as we want. So how about our dilators? These are, in the pharmacotherapy, these are our vasodilators. Vasodilators pathway is the second most used therapy in acute decompensated heart failure after diuretics. Neseritide, as most of you guys know, it was the most used drug previously. So it is a recombinant B-type natriuretic peptide. It has a venous and arterial and coronary vasodilator property, and it reduces the preload and afterload and increases the cardiac output without direct inotropic effect. In the VMAX trial, 489 patients were randomized with acute decompensated heart failure to a placebo, nitroglycerin, and neseritide. The primary endpoint of reduction of the pulmonary capillary wedge pressure from the baseline to 3 hours was significantly greater in neseritide compared to the nitroglycerin and placebo. Also, there was a benefit of the primary endpoint of dyspnea relief in neseritide, but the global assessment of the patient was not different. However, when this neseritide was tested in the larger scale trial, over 7,000 patients were randomized to neseritide versus placebo who were admitted to acute decompensated heart failure. The composite endpoint of the primary endpoint of the reported relief of dyspnea did not meet the pre-specified criteria of significance. And the composite endpoint of the death of any cause and rehospitalization, and look at each component separately, was not significant between these two groups. So based after this trial, that was the end of using neseritide as a routine therapy for the patient with acute decompensated heart failure. So what's the story about serelaxin? Serelaxin is a recombinant human 2 relaxin that regulates maternal adaptation to hemodynamic changes during pregnancy. It increases arterial compliance, cardiac output, and renal blood flow. Initially, there was a lot of excitement about this medication with the management of acute decompensated heart failure. Based on the smaller studies and initial data, there was improvement of the symptoms, biomarkers, and even there was a trend of improved mortality. However, when this was tested in a large-scale trial of the RELAX-AHF2 trial, over 6,000 patients were randomized to the serelaxin versus placebo. The endpoint of mortality and cardiovascular mortality at 180 days, and also worsening of the heart failure at 5 days, was not difference between these two groups. That was the end of using serelaxin as a routine therapy for acute decompensated heart failure. How about our pushers? These are our inotropes. Inotropes are used to improve contractility and improve the renal blood flow. Myrrenone is one of the most common inotrope used in the treatment of the patient with a heart failure. Myrrenone is a type 3 phosphodiesterase inhibitor that increases the cyclic AMP and increased inotropic effect on the heart and vasodilator effect on the vascular. This was tested in the Uptime CHF trial, which was 951 patients were randomized with the acute decompensated heart failure who did not need an inotrope for the perfusion, but they were randomized to 48 hours of the Myrrenone infusion versus placebo. The primary endpoint of the hospitalization for cardiovascular cause within 60 days, length of stays, and then death from the readmission within 60 days was not difference between two groups. And actually, there was a significant more complication associated with the Myrrenone, including the hypotension, atrial fibrillation, and there was even a trend to increase mortality. So therefore, the Myrrenone used as a routinely for acute decompensated heart failure was not recommended. So how about the other inotropes that they have less effect, inotropic and vasodilator effect? One of these medications is omecamtiv mecarbil. Omecamtiv mecarbil is a selective cardiac myosin activator that increases the stroke volume by increasing the duration of the systole rather than increasing the contractility rate with the, similar to the other inotropes. So maybe it has a less side effect compared to the traditional inotrope that we use. So this initial data was very positive as far as the hemodynamic effect, increasing the stroke volume and ejection fraction. However, when this was tested at the Atomic AHF trial, which was 600 patients were randomized to a placebo and 3 different group of omecamtiv mecarbil with a different concentration and dose. The primary endpoint of relief of dyspnea within 48 hours was not different between T groups. There was a slight improvement of the dyspnea compared to placebo and a higher dose. However, looking at other secondary endpoints such as worsening of the heart failure, death, and rehospitalization, there's not different in these two groups. So it seems that we lost all the hopes. Whatever we're doing with this medication is not working and the way we need to treat our patients. That was nicely, but we learned a lot from these trials. And this was nicely written in why Dr. O'Connor and the Y-negative trials are positive in a heart failure patient. So we have learned a lot about the pathophysiology of acute decompensated heart failure. We have decreased the use on harmful and ineffective drugs, therefore saving of thousands of healthcare dollars and decreasing the harm for a patient by using ineffective and harmful medication. And we also understand the predictive of acute decompensated heart failure and cause of mortality and high risk. So with that, I'll switch the gear a little bit and talk about some of the devices that's coming in this area. So the large unmet need of and lack of significant progression and development of effective pharmacotherapy in this patient population has stimulated an interest in developing devices in this era. Some of these devices strategies that we use are focused on decreasing the venous pressures, increasing the renal arterial flow, selectively vasodilate renal artery, and remove excess fluid. I will highlight some of these devices. And as we talked about, when we look at the tools, I think about them as these 4 categories: removers, dilators, puller, and pushers, and we'll keep the same theme here. So the puller. This device directly reduces the CVP, enhancing the renal blood flow, and increasing the urine output. And this is Ringo, my dog. He's a great puller. The first device is a precardia device. This is a catheter-mounted balloon and pump designed to intermittently occlude the SVC. It's positioned right above the SVC and RA junction, and balloon inflates and intermittently occludes the SVC. The figure in the panel, the B, shows the SVC, C, where the device is. I'll show a movie to kind of illustrate that a little bit better. And the panel D shows when the balloon is completely inflated with the venogram. So in this movie, this is how we implant the precardia. On the left, the balloon is right above the RA junction, between those two markers, and that's how the balloon gets inflated right about the SVC and RA junction. And the movie on the right, it shows the venograph after the device is fully inflated, and there's a stasis of the blood and preventing blood coming to the right atrium from the SVC. At least most of it. There's some blood goes through. This device initially was looked at the venous HF trial. The primary endpoint of freedom from the device and procedure-related major adverse event was met in all 30 patients who were enrolled in this trial. The secondary endpoints were hemodynamic and urine output. The right atrial pressure decreased by 34%. Pulmonary capillary wedge pressure decreased by 27%. However, the cardiac index and mean arterial pressure remained unchanged. And that was very important in contrast to the previous trials that has shown that when we occluded the IVC completely, there was significant drop in the blood pressure, and those devices were abandoned. But this device showed that there was no significant change in cardiac output and mean arterial pressure. Urine output was increased by 130% in all the treatment group, and among the subset of patients who diuretic dose was not changed at all, the urine output still increased by 100%. We, as Dr. Martin mentioned, our center has the highest experience with device. We are the higher enroller in the precardia device. And this is, we published our center experience. This is we enrolled 13 patients. This is the demographic of these patients shown in the table. And during the therapy, the right atrial pressure, the pulmonary capillary wedge pressure was decreased significantly compared to the prior 24 hours. And the urine output was increased. And what was interesting that has been not reported before, this effect persisted even 24 hours after device removal, which was kind of a new finding that was not shown before without changing a diuretic dose. So what are some of the proposed mechanism of action? That could be based on as we talked about, the Frank-Starling curve, but bringing the preload to the more favorable place on the curve. It could be based on the biventricular interdependency by decreasing the right ventricular pressure and volume and enhancing the left ventricular stroke volume. And the third could be based on the cardiorenal unloading and reducing the right atrial pressure, causing the renal vein improving the renal vein impedance and increase renal perfusion. So looking more into the mechanism of action of this device, this is the pressure volume loops that was shown actually by the catheter by Naveen Kapoor at the time of the inflation of the SVC. As you see in the green, the left end diastolic pressure was decreased during the inflation. The stroke volume was increased during the inflation, but there was no difference in blood pressure. Furthermore, we looked at this with the stress blood volume pool using the hemodynamic stimulator Harvey, which was which the stress volume blood volume pool was decreased by 22% from at the baseline to 3 hours after device removal without decreasing the cardiac output. Actually, there was a trend to slightly improve the cardiac output. We also looked at the natriuretic effect of the precardia device. Urine electrolytes were measured at the spiked urine before, immediately after, and 24 hours after device removal. The urine sodium and urine sodium to creatinine ratio was significantly improved during this support compared to the baseline. And this increase actually persisted 24 hours post-device removal, which is consistent with what we found in our center, that the improvement of the urine output still persistent 24 hours even after device removal. So for further understanding the mechanism of action and physiology of this device, and mainly for all the really IVC, SVC occlusive type of devices, we proposed, and Dr. Bimraj and I, with the help of the Abiomed team, has designed a sub-study that has, as part of the national trial. We are looking at the effect of these devices during the inflation on the renal, venous, and arterial flow pattern changes at the time of the device and after that. And also we are looking at the omics and proteomics changes of the renal and cardiac biomarkers with the before, during, and after device therapies. So this is the inclusion criteria that we use for enrolling the patient, and we're currently enrolling for this patient. These are the adult patient who has NYHA class 3 to 4, stage C to D systolic heart failure. They have elevated right and left ventricular, right and left-sided filling pressure, inadequately diuresed even with the IV diuretics, and there still has a symptom of congestion and with the GFR more than 30. The other device in this pooler category is a percutaneous transluminal caval flow regulation, or PTCR. The caval flow regulation is a natural phenomenon that is guided by respiratory phases. The PTCR is a percutaneous device that is designed to achieving the regulation of the caval flow from the IVC to the right atrium. The first in-human study was done in 6 patients with the IVC occlusive for 30 minutes. At that time, there was a significant decrease in the systolic right ventricular pressure, mean pulmonary arterial pressure, mean capillary wedge pressure with decrease without changing in cardiac output. This device is currently in a trial. To mention another device worth mentioning that's coming is a Doria catheter. The Doria catheter is deployed right below the renal arteries. Therefore, it causes the partial obstruction of the venous flow, resulting in reducing the cardiac preload and venous congestion. In the first in-human trial, there was no major adverse event with this trial, and CVP was decreased significantly with improving of the urine output. So we'll move to the other devices called pusher devices. The decreasing the renal perfusion is a common cause of decreased urine output with heart failure. We usually use the vasopressin to increase the blood pressure, but that can cause the renal arterial constriction. Therefore, it could blunt the renal perfusion. Therefore, we are looking to the devices to improve the renal perfusion without causing the renal constriction. This is my son, Lucas, wearing a Buzz Lightyear outpear, ready to push. The first device is a Procerian device. The Procerian device is aortic, also known as aortic device, is a pump that placed in the descending aorta right above the renal arteries. And it is in the first trial, there was 30 patients was enrolled, 25 patients underwent device implantation. And in the average day of therapy was about 4.6 days. And the first publication, as was shown in the, this graph or picture on the left, there was a significant improvement of the fluid loss up to 10 liters, and the hemodynamic effect of CVP wedge pressure was decreased with improving the symptoms of the dyspnea of the patient. That's how the device looks like under the floor and outside the body. This is currently enrolling in the pivotal trial. There are a lot of devices that are coming in this arena. Some of them worth mentioning, which are a trial, are a Rayton catheter pump and second heart assist, which is the idea is similar to improving the renal perfusion without causing the renal arterial vasoconstriction. So moving to the next tools that we have are dilators. So as we know, with the acute decompensated heart failure, the vasoconstriction of the splenic vasculature redistributes blood to the cavity, to the thoracic cavity, which increases the systemic and pulmonary venous pressure. So in this area, some of the devices that are coming here is a proof of concept with the splenic HF1 pilot study. With this patient, the splenic nerve were blocked temporarily using the lidocaine, resulting in the reduction of the mean pulmonary capillary wedge pressure, mean arterial pressure, and increasing the cardiac index with improving the patient's symptom without causing systemic hypotension. This trial is enrolling right now, and it's very early in the stages, and the technology is getting more refined and more practical. So switching shift to the removals. These are the direct removal of the fluid of sodium and the water removal strategy, which has been around for a long time. The aquapheresis by ultrafiltration, peritoneal dialysis, and dialysis has been investigated. However, the data has been mixed. There were some advantages, such as net fluid loss, which was shown in the unload and avoid HF trial. However, this did not hold in the patient with the worsening of the renal function in the CARES HF trial. This is my other son, Julian, in the construction worker outfit. So what are some of the new devices that are coming in this area? There's a pump called Alpha pump. This has been used in the patient with the cirrhosis and who require frequent paracentesis, and has been used to decreasing the need for the frequent paracentesis. It's a fully implantable device, which is two catheters. One implanted is a peritoneal, and the water in the bladder, and the sodium-free solution is infused into a peritoneal cavity, which removes the excess sodium, and the Alpha pump returns this fluid into the bladder, and patient urinates it. So therefore, removing the sodium directly. Another interesting system which has been looked at is a reprieve system. The reprieve system is an automated fluid management system that allows more accurate control and the target fluid balance by measuring the urine output and replacing the excess volume by normal saline. The advantage of this device works in the conjunction with diuretics and maintain an intravascular volume and renal perfusion. Therefore, there's a potential to avoid upregulating of the renin-angiotensin-aldosterone system and detrimental effect on the hemodynamic. The trial was a Target 1 and 2 trials, with patients were enrolled. The primary endpoint was the accurate urine net fluid of 200 milliliter per hour, which was met. And secondary endpoint of the weight loss and improving the renal function was achieved with this trial. So it's an interesting system to me because most of the time when we start patients on dialysis, patients become dependent on dialysis, and it's very hard to wean them all after. With this system, we are hoping that works in conjunction with diuretics, so the patient kidney still be actively producing urine and keeping the renal perfusion of the kidneys appropriately. So where to go from here? So we have, we talked about the medical therapies. That's some of them has been used routinely, and we're still using them. The data about them has been mixed, and some of them are disappointing. There are a lot of new devices that are coming to the market in the trials, and obviously most of them are still in a trial early on and maybe not readily available. So where to go from here? So do not forget about the GDMT and the roles of the setting in acute decompensated heart failure. Even though in the last few decades our focus has been mainly on the decongestion of these patients. However, we have not taken advantage of the additive benefit of early GDMT and up-titration of this. For the residents and fellows, the young people here, this is Mr. T from the A-Team and 80 shows, if you guys don't know. So the benefit of the four-pillar GDMT has been well established in the chronic heart failure, as the grand round was given here by Dr. Kittleson about a few weeks ago. There's no question that this therapy works for the patient with the chronic heart failure. These are our beta blockers, angiotensin receptor, neprilysin inhibitors, ACE inhibitors, ARBs, aldosterone antagonists, and SGLT2 inhibitors. And by combination, there's a significant improvement of the symptom mortality benefit. However, the benefit and safety of these devices in the setting of acute decompensated heart failure and how aggressive we will up-titrate this is not well established. Recently, there has been multiple studies that have been looked as benefit and safety of these strategies for optimizing and up-titrating GDMTs early on in the setting of acute decompensated heart failure and in the setting of the decompensation. So let's look at the sacubitril valsartan, or also known as Entresto. In Pioneer HF trial, patients were admitted with acute decompensated heart failure were randomized to sacubitril valsartan versus enalapril. The primary endpoint of the change in the NT-proBNP from the baseline at the mean of the 4 weeks and 8 weeks was achieved in 29% greater reduction with the Entresto group versus the enalapril group. And the safety profile was same in these two groups. And for the first time, we are now seeing some clinical and outcome benefit. There was a reduction of the composite endpoint of the death, heart failure hospitalization, need for LVAD and transplant listing, which was 46% lower in the patient with Entresto versus enalapril. SGLT2 inhibitors, these are the drugs that is coming and has shown a lot of benefit for our patient with a heart failure. What about in the setting of the acute decompensated heart failure? In the Impulse trial, 530 patients with acute decompensated heart failure, regardless of ejection fraction, were randomized to empagliflozin versus placebo. The win ratio analysis was used. Empagliflozin was superior in 53.9% of the paid comparison, yielding a win ratio of 1.36 in the favor of empagliflozin. There was also a quality life improvement, which was measured by Kansas City Cardiomyopathy Questionnaire, which persisted 90 days after discharge. Again, we are seeing some clinical and outcome benefit with the SGLT2 inhibitors. The STRONG-HF trial was a trial of optimizing and starting patient on the GDMT early on. 1,641 patients were randomized to the intensity care versus the usual care with the patient who were admitted with acute decompensated heart failure. The high intensity group, the medication was started early on when up-titrated very aggressively. As we see on the graph, they were shown in the orange and red versus the blue in the conventional therapy. More patients were on these therapies, and they were on a higher, and more patients were on the goal doses of this medication. At the 180, actually, this study was stopped early due to greater than expected difference between these two groups. And the 180 days of all-cause mortality and heart failure hospitalization was much higher, the mortality and hospitalization was much lower in the patient with the high-intensity group compared to the placebo. Again, we are seeing more clinical and outcome benefit. So in the last 2 decades, our effort has been mainly focusing on decongestion and decreasing the preload, as we have discussed in all the trials that we talked about. However, recently there's multiple trials have been shown the safety and more importantly the benefit of early initiation of the GDMT in the patient who are getting admitted with acute decompensated heart failure. So if you think about why this is happening, maybe this has been what we're doing is similar to the tourniquet effect, which was Dr. Eugene Stead was described in 1940. He described that when with inflating the tourniquet, there was an increase of the pulmonary capillary wedge pressure. There was improvement of the symptom transiently, but there was obviously there was a rebound effect, and this was very transient. So by decreasing the decongestion, even though we are showing some short-term benefit, but if we stop this earlier and we don't start the patient on the therapies that can change the course of the disease, we are probably doing same thing with and have a rebound effect similar to the tourniquet effect that was described. So therefore, the strategy should be changed from only focus on the decongestion and early which is very important part of the therapy, to early decongestion, followed by early initiation and aggressive up-titrating of the guideline-directed medical therapy. In this case, and only in this case, we have a chance to change finally the course of heart failure progression and the patient with acute decompensated heart failure. So here's my proposed strategy. Start early decongestion with diuretics and decreasing the preload. Start thinking about how augment and decongestion with the other pharmacotherapies and devices that are coming to achieve this goal faster and more efficiently. And then finally, start guideline-directed medical therapies and up-titrate them aggressively in these, even during the hospitalization, as aggressively as you can as patient tolerates. And finally, we shouldn't forget that the heart failure is a spectrum, and the patient can move from one stage to the next stage. Therefore, this patient needs to be frequently assessed and use all the available tools to identify if the patient moving from one stage to the next stage, especially if they're progressing from the pre-cardiogenic shock to cardiogenic shock state, in order to intervene more appropriately and in a timely manner and save the lives of this patient. So in conclusion, acute decompensated heart failure is characterized by a multifaceted pathophysiology with involvement of numerous pathways that contribute to its complexity. The management of acute decompensated heart failure heavily relies on reducing the preload, emphasizing its critical role in alleviating heart failure symptoms. Initial management of the pharmacotherapies has shown some variable effectiveness, reflecting the need for individualization and of the treatment for this patient. Promising new devices are being evaluated and their potential to enhance decongestion, improving renal perfusion, and overall treatment of acute decompensated heart failure. And there's a shift of paradigm for early decongestion, followed from early and aggressive up-titrating of the GDMT to change of the course of this therapy and acute decompensated heart failure management. I hope I didn't bore you with talking a lot about the pressure volume loops. I had to do it. Like here, my son Sean, I explained to him why you cannot have 2 ice creams and a cake at the same time, but now that I bought it for you, please don't tell your mom. But thank you so much for your attention.
Thank you, Ryan, for the, I think, a very nice journey through some of our past history with medications and looking to the future with some of our device therapies. While everybody else is thinking of questions, maybe it's just because I'm old, but I noticed that there was maybe one medication that we didn't talk about for heart failure therapies that is a very potent vasodilator that we use pretty regularly. Maybe give us a little bit of your thoughts on the use of nitroprusside or nipride for heart failure in the setting. I
knew you were going to ask that. Yes, of course. And there's definitely a role for nitroprusside in the patient. We see them in the with company with acute decompensated heart failure, cardiogenic shock, especially this patient, as we talked about. There's definitely a lot of sympathetic activation and vasoconstriction, and there we see this SVR is elevated on this patient, and we've shown multiple times clinically and in trials there's definitely a role in nitroprusside, and we use it regularly. And then since you've been here, we've been using it much more.
It's a great guy.
It's a good drug.
Yes. Dr. Zachary.
Ryan, that was very nice overview of where we are, where we should be. A lot of challenges in between, but we learn from them. I fully agree with you about medical therapy, the standard medical therapy guideline. On top of this, the question is, with more and more pillars of this, what would be your advice of how do you start somebody who's decompensated on all these different medications? Which ones is safer? And interestingly enough, we don't have true guideline as to which and how in a complex kind of situation for the general cardiologist, for the internist at times who manage these patients.
Yeah. Thank you, Dr. Zago, for a question. I think this has been looked, and even in the setting of the chronic heart failure, which is patients are stable, has been challenged how to start that. So there's more strategies, which was recently the paper published that Dr. Killiston talked about how to start this medication in the setting of the chronic heart failure. And acute decompensated is even more challenging because, and it's really how the patient present and what's going on with the patient. For example, I'll give you an example. A patient are on inotrope. We start them on inotrope, or they are decompensated, and they need some like vasodilator. These are the patients that I usually start over my ACE inhibitor, renin-angiotensin receptor, and aldosterone system inhibitors, over ACE inhibitor, ARNIs first. Patient with if they're coming very decompensated and there's a question about the low output, the beta blocker is going to be hard to start. So I think the strategy that I usually approach with these patients, if somebody comes with acute decompensated heart failure, first I try to decongest them because we have to get them, focus should be in the early decongestion. When they are a little bit more stable, then I would add the drugs as depends on what's the patient. If they have a blood pressure, I go with the ACE inhibitor or ARNIs. If they're tachycardic with the beta blocker, with the atrial fibrillation, I use my beta blocker. SGLT2 inhibitors is a great drug that does not have a lot of side effects, does not have a lot of effect on the blood pressure. It's an easy drug to start early on. So that's a drug that we use. And in conjunction spironolactone, I use it a lot with diuretics because it not only helps with diuresing, it also helps with the potassium retention. So it is very personalized, but I think the goal should be, at least for me, if patient tolerate, they should be on all 4 pillars before getting discharged. Because it's hard, as you know, to get these patients and start them on a timely manner. We try to get them between 7 to 10 days and have a clinical clinics to up-titrate this medication. But my goal is to have them on these, at least 4 pillars before discharge if they can.
Ryan, great talk. I walked in a little bit late, and when I walked in, I felt like You're giving an interventional cardiology talk.
Yeah.
I always knew that there was an interventional cardiologist in you somewhere back from the Cleveland days. So, jokes aside, great talk.
Thank you.
I agree GDMT is critical, but it's also very exciting to see the role of device therapies in heart failure, both chronic and acute. And, I like the data that you shared. It's still early days, I think, for heart failure, but it's very exciting. We've seen role of clips in mitral and tricuspid, and recently at ACC the shunt trial was presented, which was unfortunately negative. So this is a very complex field, and just your thoughts on where this field is going, how you see this sort of collaboration between interventional and heart failure in order to have the best patient outcomes.
Yeah, I think this is this as you mentioned, Sachin. These patients are very, very complex. They need really a village to take care of them. We need the support of interventional, our electrophysiologists, our imaging team. There's definitely a group of patients that they're different group of patients with the cardiogenic shock patient, which I really kind of left them off this talk. There's a clear role of early intervention of these patients and the mechanical circuit support, which we rely on our interventional colleagues and our surgeons to help us with that. This new era of this acute decompensated heart failure, when these new devices are coming, I think it's very exciting because there's not a lot to do for these patients. They don't need mechanical support. They're not the place they need the LVAD or transplant, but they continue coming to the hospital because we really cannot effectively decongest them and keep them in the hospital. So these are devices, and I introduced this concept, and I think actually published by Mahawash, this invasive heart failure specialist, which is coming. There's a lot of heart failure are interested in the device in a collaboration with interventional to be able to take care of this patient. But it is an evolving field. A lot of things is coming, and we definitely need a lot of support of our interventional and their skills to manage these patients. I appreciate it.
Okay, Dr. Yousefzai, I think it's very important, as you said, of that combination. But I do, as you pointed out, want to reemphasize that we know that these devices and interventions are not in place of GDMT. They're in collaboration with GDMT. And I think I really ask help of our colleagues of reinforcing that to our patients, because the patients really like the concept of having a procedure done and not having to worry about all these meds anymore, because it's just kind of I think our society right now is an immediate gratification of like something done and I'm better and it's off. But this is all in collaboration with GDMT. And sometimes GDMT should be first in some of these, things as opposed to other interventions. Some of are in sequence. So I think, it's really nice to see you highlight the GDMT with these therapies, because it is that collaboration. And sometimes, like I said, it's sexier and funner to talk about some of the devices, but some of the old, medicines that just need to be taken every day, I think will give us the great advantage as well. Dr. Valentine.
And that was outstanding. Simplifying an area that's very complicated. And I think you brought up the illusion of combining the science with art. I mean, there is a big art in this. A couple points. One, coming from a lens of pulmonary cardiology, 3 decades. Do you think the grim results that you had at the beginning of your talk is underestimated or overestimated?
I'm sorry, you guys repeat what result?
The grim outcomes of
Of just
30
medication.
days, 6-month, and 1-year outcomes in heart failure. Do you think those statistics are under or overestimated? I have a little bit of an answer, but I want to hear your point first.
Yeah, I talk about the setting of this GDMTs.
No, just
so-
No, the grim results of patients with decompensated heart failure
okay.
admitted,
Yes,
30 days
yes.
survival mortality in 1 year.
Yeah, these are data based on the national. I think some of these results may be underestimated, because I think there are some of the patients that hasn't been captured, and some of the patients that there are missed on the follow-up to do it. But these are the by itself they're pretty grim facts. They are. I think there are some components that are underestimated because might not be able to catch all these patients on the follow-ups.
I think eerily they're almost grossly underestimated, because I've heard so many times, going on 3 to 4 decades, patients who have several pneumonias over a year. And if you remember the past, Osler, pneumonia is a friend of the aged. Now, Osler was gender sensitive. He didn't say it was the friend of the old man. He said it was a friend of the aged, pneumonia. So pneumonia is always going to be there. And I think as the patient population has aged over the last 100 years, you know, we're calling a lot of decompensated heart failure pneumonia, and then eventually it gets sorted out. So I think it's a gross underestimation based on that. I don't know how to verify it. Maybe we can with our augmented intelligence coming around the corner. The second thing, there's an old quote, in all of science, error precedes the truth. And it's better that it should be that way, that error's first rather than last. And I'm harking on the point of devices. Devices have a different pathway of getting approved rather than medical therapies. And when we do our controlled trials, we're very specific and careful on excluding particular individuals. And all of a sudden it gets released, and our irrational exuberance tries to rush people into these therapies. How can we control that before we make mistakes after everything gets approved, which we've proven we've done that with medications?
Yeah, absolutely. I think there's you have to be careful. You have selective. Shouldn't forget about our usual standard of care. Think about the medication that they've definitely shown the benefit over years and years, over decades. Should be our first approach. The devices are a complement for some of the patients that we're struggling. You know, patients we are trying to diurese them, decongest them. They have a renal failure, worsening of the kidney function. So there's a role for these devices. But to your point, I completely agree. You have to be very selective. You have to wait to see what the outcome of devices are, safety of device, and then the right selection of the patient before jumping and putting this device in the people. Absolutely. Point well taken.
Dr. Akai? You?
Yeah, I mean, I don't want to create a conflict, but my view is different because I'm a device guy. Actually, I just removed one of them, so I missed the early part of the presentation, and I'm sure it's great. But so heart failure management is medical, but to me is when it becomes acute decompensated heart failure, which is like a shark attack, is biting your one piece of an organ, and it should be the device therapy should be the gold line. And I think there is I'm sure there is a combination always, but you know, like when we had one of those yesterday. We put it immediately. Today the patient is different. The reversing and impacting the end organ is the main key here for the therapy than resuming the blood pressure or how the patient looks. So I think for that reason, device therapy should be way early, first line therapy. But again, I'm not talking about heart failure management. I'm talking about when the sharks are attacking and biting piece of your kidney, liver, and all other organs. Your lactate is increasing. There is no GDMT anymore.
Yeah. No, fair point taken. I think the first part of that, I think in the patient of the cardiogenic shock patients, refractory cardiogenic shock, the patient that you are mentioning with the shark attack, you have to do everything. No question.
But decompensation is also a shock patient.
Not all the decompensation. We're talking about more patients. They don't need mechanical support or a perfusion support. So that was kind of a little bit more focused on that patient. But your point well taken. Patient with cardiogenic shock, they come, they have a lactate is up, kidneys are worse, liver are worse, they're in a shock. Device therapy as soon as we can to perfusion. Yeah, absolutely. Point well taken.
So, Ryan, as you've been lured by Dr. Goel and others in the word of intervention, I also see a preventive cardiologist emphasizing GDMT, so that's great. You know, I really like your point on the early initiation, at least within the hospitalization of the SGLT2 inhibitors, but when we look in the real world, at least at a system level, there seems to be a lot of hesitation because of the concern about decay. How do we deal with that? I see that even here and other places, is there a system-wide policy about initiation of the SGLT2 inhibitors early, which I totally agree with you that we should be doing that.
Yeah, I think it's a lot of hesitancy. I think it comes with the learning, curve to feeling comfortable. When these drugs came as a heart failure, we were very hesitant because we felt there's a diabetic medication, how we start them, we didn't know that much about it. The more and more data they come, they shows their safety, how they're safe, they're started as in heart failure and acute decompensated heart failure. I think everybody feels more comfortable starting, and I think as you see, there's a move in our hospital. Before, it was very difficult to start this patient. At least here, I think we are have a support of a pharmacy and our system to start this medication early on. I think like every other medication is going to take some time and some learning curve, but as far as the DKA, has to be selected for a patient, especially where the type 1 diabetes or before the procedure, there shows some DKA risk, but generally these medications are pretty safe to start early on and continue without any complication. But you definitely need a system support to be able to start these patients on this medication.
Excellent talk, Ryan. I was just going to follow up on Khurram's point that I think, how do we identify these patients? I think that's the key where I think the spectrum of identification does not happen early enough. Whether it's pre-cardiogenic shock or, like Hakan was saying, not everybody's in cardiogenic shock. I think the early identification is the key. And any comments on, how we can improve that?
Yeah. I think we need some, like Dr. Nasir too, with the system-wide alerts, be able to get the alert to the clinician. What are the criteria? What are the patient? What are the signs? What are we looking? How we can identify this patient early to start them on the GDMT. Kim's been working on identifying the cardiogenic shock patient now for a while, and the system has been challenging. And then there's for acute decompensated heart failure, as a heart failure, even as a cardiologist, we see a very small percentage of these patients. Most of these patients are seen by our hospitalist colleague, our internal medicine colleagues. So those early identification starting is going to be a key, and we need more system-wise approach to this.
I'm going back to the complexity of the situation. Interestingly enough, heart failure is one of the highest admissions diagnosis to any hospital. So with variability of approaches, you're going to have variability of outcome. And the more you define, so you had a discussion here between, where is shock, what is close to shock, and other things. So personally, I would try to get some criteria among your specialties to decide, this is a scenario, this is a different scenario, this is the third scenario, and how do we approach it using so many different therapies to hopefully come up with a consensus among the treating physicians of how to, because otherwise you're going to have so much variability and so much variability in outcome. So, that would be my advice for the heart failure specialist is get together, define these scenarios so you can construct trials around them. And the patient population is so prevalent that you could test it rather very quickly.
I think, sorry to jump in, Ryan, but I think the bigger thing that we've all talked about is, and I don't know exactly how to do it, is we have to increase the fear of heart failure. The population has become, I think, so numb to heart failure that it's just they have heart failure. I think the statistics you show here, the outcome for heart failure is worse than any cancer that we have. But if somebody walks up and says, oh, this patient may have lung cancer, or this person may have pancreatic cancer, everybody gets all revved up and starts what do we do? How do we treat it? How do we do that? But we don't see that with heart failure. And so I think that's part of what we're trying and continuing the message of showing the statistics, not to scare people, but to realize, and I think the most exciting thing about heart failure, as you've seen, we have medicines to intervene. And I think some of the best slides that I think that have been really impactful, and maybe we just need to distribute more, is the year saved. And when you start looking at, when you add the GDMT in a 50-year-old gentleman, if you're adding 8 to 10 years of lives gained from these patients. And I think continuing some of those types of educations, I think because for a long time, we just felt like that people had heart failure because you got old and then you died. and then you just made them feel better until they died. But I think obviously in 2024, we're in a completely different era, and I think we just have to continue, and hopefully by education of like the data that Dr. Yousefzai presented and the excitement in the field, and I think that's something we need to harness. The excitement in the new things, the excitement in things to get people's attention, but driving back to the core, which you did wonderfully of the GDMT and reminding that this is how things move forward. So in the interest of time, I think we'll finish today. Thank you for everybody for your participation. Thank you, Dr. Yousefzai, for a great presentation.
Thank you.